Hi, I'm Dr. Noelle Northcutt.
And I'm Dr. Gerard Saleme.
We're excited to review the lumbar puncture procedure today using static ultrasound guidance as well as the classic landmark approach. To successfully perform an LP safely, we encourage all viewers to familiarize themselves with their home ultrasound device. Knowing how to adjust the preset, adjust gain and depth, as well as use the calipers for measurements are essential functions.
Ultrasound has been shown to decrease the number of needle insertions and redirections, as well as increase the number of successful first attempts, specifically in patients with non-palpable landmarks, spinal deformities, or prior spinal surgeries.
The goals of this demonstration are to review basic lumbar spinal anatomy, demonstrate pre-procedural mapping using static ultrasound guidance as well as landmarks, and to demonstrate proper procedural technique as well as post-procedural care.
The non-skeletal anatomy can be easily reviewed through many open-access online resources. We'll be focused on the bony structures of the lumbar spine as well as the ligamentum flavum, dural complex. We will focus on the transverse processes, lamina propria, articular processes, and spinous processes. Notice that the transverse processes are separated by ligament and fascia. In contrast, the articular facets are overlapping and interconnected between the spinous levels. We will then see the lamina propria, and finally, the most medial and most posterior structure will be the spinous processes themselves. We will review the ultrasound appearance of the aforementioned structures later in the demonstration. For static landmarking using ultrasound, we will be using a curvilinear transducer with an abdominal or musculoskeletal preset. If the needle depth is expected to be less than 4 centimeters, then the operator can choose to use a high-frequency linear transducer.
We will perform this demonstration using a lumbar puncture phantom mimicking a patient in the seated position. As a reminder, opening pressure measurement requires the patient to be in a lateral decubitus position. Ensure the patient is in a comfortable final procedural position before beginning. Beginning with the classic landmark technique. Identify the superior iliac crests and draw an imaginary line between them. This line intersects the spine roughly at the level of L4, L5. Next, we will use the ultrasound for mapping the spine. Identify the indicator on your transducer and on the screen. Recall that on an ultrasound, calcific bone appears as a hyperechoic bright white line with anechoic shadowing deep to the cortex. Start with the probe in the transverse orientation with the indicator toward the patient's left. Using a small amount of gel, we are going to localize the sacrum, which appears as a long, flat, bony structure with small protrusions of the sacral transverse ridges. Note depth and gain adjustments are made to ensure the structures of interest are occupying the top 2/3 of your screen and are clearly visible. Next, we will map the midline of the spine. Make a mark above the center of the probe at the midline of the sacrum. Then slide cranially. You'll notice that the small bony ridges of the sacrum give way to a large protuberant L5 spinous process flanked on either side by the lamina propria, seen toward the middle of the screen. The spinous processes are the closest to the probe in a midline view. You may need to adjust your depth. Centering the L5 spinous process in your view, make a mark above the center of the probe. Slide up to the next spinous process and repeat. Slide up and repeat once more. You have now mapped the spinous processes of L3 through L5. Connect the marks. Next, we will confirm the midline in the longitudinal plane. Rotate the transducer 90 degrees. Note that we prefer rotating the probe to be oriented caudally so that the right side of the screen corresponds to superior spinal levels. Place the probe lateral to the marked line. First, you will see the trident sign, the distinct projections of the transverse processes. They appear separated and deep. Sliding medially, next you will see the waves of the lamina. Sliding medially again, you will see the spinous processes as islands rising out of the waves. Center the transducer such that the spinous processes extend across the screen. You may need to make a slight rotation with the probe to achieve this. Once centered over the spinous processes, confirm that the long axis of the probe is in line with your marked midline. Note that this initial midline mark can highlight spinal curvature deformity. Next, we will define interspinal spaces in the longitudinal axis. Place the transducer over the lowest portion of your marked midline. Identify the L5-S1 interspace. Center the interspace on the screen and then make a mark adjacent to the probe in the center of the probe. Repeat for L4, L5 and L3, L4 interspaces. Connect the marks to identify the interspaces. This gives you the center point of the interspace in the midline. It is helpful to create a gentle indentation using the blunt marker cap at the L4, L5, and L3, L4 midline interspaces. This ensures you maintain your mapped and marked needle insertion site through the process of skin cleansing. Lastly, we will visualize the ligamentum flavum and dural complex to estimate needle insertion depth using several methods. The probe is placed in the longitudinal orientation, marker-oriented caudally, centered over the L4, L5 interspace and the predetermined midline. Maintaining the probe orientation, slide the probe laterally off the spinous process and over the lamina, off the islands and over the waves. Tilt 15 degrees back toward the midline. Freeze this image. Using the caliper, measure the depth from skin surface to the ligamentum flavum. We now have assessed a depth of 4.2 centimeters from skin surface to ligamentum flavum. And challenges in this approach, sometimes you can't visualize the ligamentum flavum. In that case, you could use the laminal depth as a surrogate rough estimation. A second way to visualize depth is in the transverse axis. First, placing the probe in a transverse orientation centered over the L4, L5 interspace at midline, you will be looking between vertebral bodies and anticipate seeing the ring of the spinal canal created by the ligamentum flavum nearest the probe, the posterior vertebral body, deep, and the articular processes on either side. Freeze this image and again use the calipers to measure the depth from the skin surface to the ligamentum flavum. This depth is an anticipated minimum depth because it does not accurately account for the needle insertion angle and compression of the skin and subcutaneous tissue by the transducer. Some challenges at assessing depth in this view: the inability to visualize the canal ring and mistaking posterior vertebral body for dural depth, or mistaking the transverse processes for dural depth. This is another reason that taking depth in multiple views can be beneficial. With a few repetitions, the entire process of static guidance and depth visualization can take less than 5 minutes and provide confidence and preparation for a successful lumbar puncture.
Now that we've mapped the spine, let's perform the procedure. We often teach that lumbar puncture is 70% preparation and 30% execution. First, begin by adjusting the physical space you're going to be performing the procedure in. Adjust the bed to be completely flat, and the procedure can be done in either a standing or seated position, and the bed height should be adjusted based on the operator preference. Modern hospital beds may require a pausing of insufflation or use of a transfer board to ensure a stable patient position and avoid spinal curvature. This is especially important when patients are in a lateral decubitus position. Next, ensure a proper patient position with a rounded, flexed lumbar spine in either the seated or lateral recumbent position. Open the kit on a bedside table or next to the patient on the bed to allow for access to all the tools. Don a mask, then sterile gloves. Inspect the kit to ensure all components of the kit are present. You should have 3 needles, including a 25 gauge needle for skin anesthesia, a 22 gauge needle for subcutaneous anesthesia, and the spinal needle itself. The most common spinal needle included in kits used by internists are the 9 centimeter Quincke tips. Other lengths and types of needles can be used for this procedure depending on your pre-procedural map depth. You'll also find 4 collection tubes, which should be open and set upright for easy access. Arrange the tubes in sequential order as they are pre-labeled as such. You'll also find a vial of lidocaine, gauze, and betadine swabs, and a fenestrated drape and sterile field disposable towel. Prepare the 3-part manometer if opening pressure is desired. Adjust the stopcock so the flow will be directed to the manometer upon connection to the spinal needle. Use the betadine swabs to clean the skin using a spiraling swabbing motion over your mark. Place the fenestrated drape centered over your planned needle insertion site. You may extend your sterile field with the white towel included in the kit. To anesthetize the patient, drop the lidocaine into a syringe. Some kits may include a filter needle. It is preferable to use that filter needle when available. Create a skin wheel using a 25 gauge needle. Exchange the needle now to a 22 gauge needle to further anesthetize the deeper tissue ensuring to aspirate before administration of any lidocaine to avoid accidental intravascular administration. It is not uncommon to encounter stiff resistance as you traverse the supraspinous and interspinous ligaments. To reproduce the dural depth from your pre-procedural measurement on your spinal needle, you can use the centimeter markings on the manometer. In our case, we measured our spinal depth at around 4 centimeters. Pinch the spinal needle at that length with your non-dominant hand, as this will mark the point at which we will begin checking for CSF flow. Insert the spinal needle through your marked site with the bevel parallel to the cauda equina. The needle angle will be toward the umbilicus. Advance the needle slowly. Once you have reached your anticipated dural depth, begin checking for CSF flow in 2 to 3 millimeter increments by removing the stylet completely and replacing it all the way before further advancement. Once you have confirmed CSF flow, replace the stylet halfway into the needle. If opening pressure measurements are desired, place the prepared manometer onto the spinal needle after removing the stylet completely. Avoid excessive pressure when connecting the manometer complex to the spinal needle itself, as this may displace the spinal needle and make removal of the manometer more difficult. Make sure one hand is always controlling the spinal needle. The opening pressure is identified at the point at which the CSF stabilizes within the manometer. As a reminder, to measure opening pressures, the patient must be in a lateral decubitus position, and normal opening pressures are between 20 and 25 millimeters of mercury. To collect the CSF from the manometer, place tube 1 at the opening of the 3-way stopcock. Rotate the lever 180 degrees towards the patient. CSF will flow out of the manometer and into the tube quickly. Remove the manometer complex, and please note, always maintain control of the spinal needle while removing the complex. Sequentially fill CSF tubes, aiming for 2 to 4 mL per tube depending on the indication. When the desired amount of CSF is obtained, replace the stylet completely. Remove the spinal needle with the stylet in place and apply an adhesive bandage. Remember to keep all sharps away from yourself and to dispose of them adequately in the appropriate receptacles. Post-procedural care. We recommend that patients lay supine for 1 hour after the procedure to avoid post-LP headaches. Label all the CSF specimens and take care to closely close the lids.
We hope you found this video educational. Thank you for watching.